I pass the microphone to Dr. Andreoli already.
Yeah. The next speaker is Professor Vitti from University of Pisa. I think he doesn't need any presentation, so I invite him to have a talk about thyroid guidelines, thyroid nodule guidelines.
Thank you. Thank you to Roberto, who invited me to this nice meeting. Okay, we'll start with a clinical case. A female of 28 years. She had a CT scan of the mediastinum for the evaluation of the thymus, and there was an occasional finding of a nodule in the right lobe. The patient was referred to the endocrinologist for clinical evaluation. This is the ultrasound. I present this case because now is the most common presentation of our patients. Indeed, if we look at which was the definition of thyroid nodules in our old textbooks, this was defined as nodular enlargement of the thyroid by palpation, Werner and Ingvar, or thyroid tumors usually present as anterior neck nodules, and so on and so on. While now we have heard this morning in the first lecture of one of our chairman, now we define a nodule as a discrete lesion within the thyroid gland that is radiologically distinct from the surrounding parenchyma. So thus some palpable lesions may not correspond to distinct radiological abnormalities, and also non-palpable nodules incidentally discovered on ultrasound or other imaging techniques account now for the most thyroid nodules. So we know that nodular thyroid disease is very common, and in iodine deficient sufficient region is present in 15% of the population, while in iodine deficient regions it affects more than 30% of the population, and in the population which is a little bit older, in most of the people. And indeed, we know that iodine deficiency is the main factor in the pathogenesis of goiter, but also in most patients that we see, the pathogenesis is not really due to iodine deficiency, but it is indeed a mixture of external factors and endogenous factors. So this is because, of course, we human beings, we are not identical, as depicted in this nice painting of Magritte, but otherwise we are very different one from another, like depicted in this Bruegel painting. So which are really the factors that influence the presence of thyroid nodules? Of course, the first is maladaptation to iodine deficiency. Iodine deficiency per se is a factor, because iodine is a regulator of thyroid growth, but TSH is the main growth factors, but also other factors like IGF-1, epidermal growth factor, insulin, TGF-beta, were in several papers indicated as effectors of goiter and nodule formation in the thyroid. But of course, we have to be aware that there are mutations of genes involved in the thyroid growth, and indeed many of these genes, while we know several mutations that are the pathogenetic in familial goiter, we must be aware that surely there are many small genetic defects of mutations that we still don't know that lead to non-neoplastic thyroid growth. So when we find a thyroid nodule, of course, we have to know which are the real pathologic signs of this nodule. So there is a benign nodule, and this is very important to distinguish between hyperplastic nodules, which are those that we see in the presence of nodular goiter, and adenomas. And of course, we have malignant nodules. We have also pseudonodules, because are those nodules that you detect by palpation, but when you do ultrasound, you see that they really are not nodules. And these nodules are many frequently found by palpation in Hashimoto's thyroiditis and Graves' disease. So if we see what is nodular thyroid disease, we have to distinguish between nodular goiter and isolate nodule. So nodular goiter, of course, is mainly due to iodine deficiency together with endogenous factors, while in the case of normal thyroids with isolate nodules, we must know that the most important pathogenetic role is played by endogenous factors and gene mutations, while iodine deficiency is not so relevant. I want to show this slide that was shown before by Dr. Andreoli, because to me is really very much important when we speak about thyroid nodules. This is a very nice slide that has more than 25 years and was drawn by an Italo-American, and Smaksaferi, that we have known. And this is a meta-analysis, and these are not single observations, but these are papers, and it's clearly seen that, excuse me, okay, this is the problem of not having, okay. The main observation of this slide is that if you see the prevalence of nodules assessed by palpation is about 4 or 5% of the population. While if you see the presence of nodules in autoptic series, you see that the prevalence is much higher and is increasing with age. But the interesting thing is that the papers that describe the presence of nodules performed by ultrasound are very similar to the prevalence of nodules that are assessed by a systematic autoptic examination. So it means that ultrasound detects all the nodules that the thyroid has. So this is a problem, because the physician has to face very often with this problem, how to manage all these epidemics of nodules. And then at this point, the guidelines, which is the main topic of my talk, have the role to help the physician in decision-making in these epidemics of nodules. So just starting from but I will be very, very fast. From the principle, of course, you have a general idea of the thyroid function. So TSH is the main hormone that you have to measure, and also sometimes to assess the presence of thyroiditis. Measurement of autoantibodies. Important concept is that thyroglobulin is completely useless in the diagnostic workup of these nodules, while for calcitonin there is a real debate. In most of the guidelines is not recommended in all the patients who present with thyroid nodules. But otherwise, I like to call for caution in just not considering measurement of calcitonin in the patients, because it is also very clear that the prognosis of medullary thyroid carcinoma has changed a lot with the introduction of measurement of calcitonin and the assessment of nodular thyroid disease. Because if we see here, after 91 in our institution, where we measured calcitonin in all the patients, the diagnosis of medullary thyroid cancer was made in patients who had an intrathyroid cancer, not expanded to lymph nodes in the majority of them, while before 91, you see that the diagnosis was delayed, and in most of the patients, there were already lymph node metastases. And we know that the prognosis of medullary thyroid cancers changed a lot, while if it's intrathyroidal or has already spreading to neck lymph nodes. So we discussed a little bit before when to perform thyroid scintigraphy, but as we will see in the next few slides, of course, now but of course, all you will agree with that. Now we take the thyroid ultrasound as really the important step in the initial diagnostic workup of thyroid nodules. We don't perform thyroid scintigraphy in all patients, but not only for the problem of the costs. We have seen here one of our American colleagues, I don't remember where he is, where he told us the cost of thyroid scintigraphy. In Italy, we have a system which protects patients, and most of the patients do not pay themselves thyroid scintigraphy. Thyroid scintigraphy, in a sense, costs also less to our hospitals, but the problem is also a problem of use or radioactivity. So we restrict the indication for performing thyroid scintigraphy in some cases. And in this particular matter, I would say that guidelines help us, because guidelines tell us that you have to do thyroid scintigraphy in the presence of the multinodular goiter, because we want to know which nodules are hot and which are cold, to give us further indications to perform fine needle aspiration. But you perform in isolate nodules only when you have subclinical hyperthyroidism. Thyroid ultrasound, I entitled this, I don't know if my English is perfect or not, I will ask to my American friends, Joys and Sorrows. Joys because thyroid ultrasound is extremely important, not only to determine nodule size and position in the thyroid, but also to assess the presence of patterns that are suspicious for cancer, to assess the presence of other nodules in the thyroid, or the presence of cervical lymph nodes. As we have already heard, it increases fine needle aspiration, but the problem is that it detects many insignificant lesions. We have heard this also in the first presentation, so it will be very fast. It is important to have the knowledge that we have clear patterns that are suggestive of malignancy. But as we have shown, and it is the experience of all of us, is that one single character that is suspicious for cancer has very low specificity and sensitivity. In reality, you may increase a lot the specificity when you combine several signs that are suggestive of malignancy, but you will decrease a lot the sensitivity of this. And this concept have been collected in these TIRADS patterns and systems that we have heard in the first presentation of Dr. Andrioli. However, anyway, we must say that ultrasound is indeed essential, and this is recognized by all the guidelines in guiding us in the choice of nodules that you have to submit to fine needle aspiration or not. And all the guidelines agree on that. And this is a slide that shows us how you have to combine two things, of course, which are the size of the nodule, of course, because there is all this debate whether you have to submit to fine needle aspiration small nodules or not, and we can speak about that in discussion if you want. But anyway, all the guidelines take into account the two parameters, the size of nodule and the suspicion at US. And of course, this suspicion at US, you have to measure the suspicion at US using one of the the systems that are in the literatures. And as I said in my comment to Andrioli, of course you have to have in your place to adopt one of these systems, and that be consistent with that, because you have to know how your system really works or not. And you can do that only in our clinic. So this is a very nice representation of all these words, and you can, in one figure, have everything. So this is very nice of our friend Garib, who in endocrine practice made this slide, and the indication for fine needle aspiration increases when there is increasing patterns of suggestive of malignancy. Then we have cytology, and when you have decided to perform fine needle aspiration, and you have to rely on one of the systems that are recognized. Actually, I have to say that all the systems are good, of course, are good enough, and all the systems are good if you use one system and you know which is your result using that classification system, of course. So you have to rely in your center which is the correspondence between your cytology and histology. This is obviously very important. So you have not to rely to one system, ultrasound system, but you have to have the experience of your center, and this is the same for cytology. I like the Italian consensus because we worked a lot on this Italian consensus with several people who are present today here. And also to this T3A and B, I will have a comment. We tried really to distinguish the pathologic patterns of tier 3A, which is in our indeterminate but benign, and tier 3B, which is indeterminate but a little bit more suspicious. And we think we did a good work on that. But anyway, cytology is really now important because it gives us the further important indications to know which is the further step of our management. And I am less optimistic than the presentation that I've had on cytology. This is a slide that we discussed together with several other people, but taking the results of several centers, unfortunately, we have non-diagnostic. Taking all the centers, we have 10–15% of non-diagnostic. And of course, in specialized center, this number is very much smaller. But anyway, taking all the centers, this is the percentage. Benign, most of the nodules. Indeterminate, unfortunately, in 10–20%, and suspicious or malignant, 3.5–10. Actually, I think that the 5% is the mean that you have. So in this nice slide, and again, this is the ASA AME guideline of endocrine practice, is shown which is the general management of nodules according to cytology. And of course, the risk is very high when you have suspicious cytology and so on and so on. And then you have treatment, surgical treatment when the suspicion is high. But just to have a summary, very brief summary of what is the clinical management, and is that in fine needle results, cytology results that are indicative of suspicious for malignancy, surgery is usually recommended. Of course, now we have seen also in some of the previous talks that there is an active surveillance protocol that was performed for the first in Chinese series, but also in the United States. And now I tell you that 2 days ago, is published on GCM, the first Italian series of our center. In the Thai3B, Thai3F subset, surgery is recommended in the majority of cases, but of course this must be tailored on the patients. In Thai3A, usually you don't perform surgery, and if you perform surgery, usually is not in the presence of multinodular goiter, is lobectomy. In benign nodules, this is what we had before, so is follow-up in most of the patients, and we will see the indications for LT4 treatment in the next speech. Surgery, if there is a nodule of large size which is causing compressive pressure symptoms, but now the indications for management of benign nodules have changed. We have the ethanol injection for cystic nodules. Of course, we have radioiodine treatment for hyperfunctioning nodules, but of course the indications for radiofrequency or laser treatment is increasing and increasing. So what will you do in a nodule like that? You leave it or you perform fine needle aspiration? You see, Roberto, he doesn't know. He is going to perform fine needle aspiration because this nodule has several patterns that are suggestive of malignancy, coarse calcifications, margins that are ill-defined, and maybe also some capsular invasion. But this is one patient that I've seen. This is an old male, 85 years, who performed fine needle aspiration in our center and had a Thyroid, but he had previous heart failure attacks, ischemic cardiopathy treated with 2 bypasses, and he took more than 10 drugs daily. So I told him, look, it is very difficult that you will die for a thyroid cancer. So thyroid nodules are nowadays frequently detected by the imaging techniques. Only a minority of these nodules will cause a significant health harm. Thyroid ultrasound is the main culprit for this frequent detection, but also the main tool to stratify the risk of cancer and then the strength of indication to FNA. Besides US patterns, the general clinical context has to be taken into account to establish the indication to initiate a diagnostic workup. Guidelines help the physician in the choice of diagnostic workup and treatment. And I want to conclude with this slide, which is a slide which is very much important in general medicine, in general medicine, because you see that when you see a screening, you talk about screening of a disease, the screening has the value of the screening is a curve. So when you the screening, the value of the screening is increasing to a point, but then the benefits will plateau, while the harms plus the costs will increase. So the screening at one point is not useful for the general health of the people. So I think that this slide is very much appropriate for nodular thyroid disease. Thank you very much.
Thank you very much, Professor Witte, for your presentation. Now I want to ask to the audience if there are some questions to Professor Witte.
Paolo Limone, Torino. Thank you, Paolo. I have a question about the case you showed us. But do you start from the nodule or do you start from the patient? Because there is a difference. Because if I start from the patient, I probably don't perform a fine needle aspiration.
Right, but this was indeed the case. This was really a patient of mine who came with already a result of a fine needle aspiration. So I made the ultrasound and told him and his family members, look, you have 98% probability to have a thyroid cancer, but this is something that will not cause anything to you. Because he didn't have nodes also. So it was limited to the thyroid and it was a T1 now in our classification because the extracapsular invasion is not considered anymore.
Thank you for an interesting presentation. Milo Žarković from Belgrade. Now I wonder, what's the point of doing FNA in a patient with high probability of malignancy on ultrasound? Because you have pre-test probability of 90%. Whatever test you do after that, you cannot reduce post-test probability to 20%. So instead of doing an FNA, we should send those patients straight to surgery. What do you think?
Well, you have a very straightforward approach. Well, I must say that all the people that are sitting here who are very practicing ultrasound every day may have your same idea. But I think that you must have something more just to send the patient. In this case, I've said you have 98% probability that you have a cancer. I agree. But anyway, I think that you must have also the result of fine needle aspiration for. I don't know if everything agrees with me, but I wouldn't send.
I mean, mathematically, you cannot reduce post-test probability to less than
Yes.
20%.
What we have said, when someone asks me this, what you do if you have an ultrasound pattern that is almost indicative of malignancy and you have a Taiwan response at the fine needle aspirate. Okay, I look at the patient very carefully, much more. I see him again. I repeat the fine needle aspiration. I try to make I make a research of BRAF, but we can speak a lot about BRAF. I don't want to spend all the people the world because we have positivity of BRAF only in 50% of papillary thyroid cancers. I repeat fine needle aspiration. At that point, I still have tier 1, and I know that this patient has probability of cancer. I send him to the surgeon, but I try before to have an answer from FNA.
Thank you.
This is what I do. Maybe I'm wrong, but this is what I do in our clinical practice in our center.
Other questions?
I don't know if someone, Jill, you do a different way? Because we rely on our ultrasound, but you have to have something more in your hands.
Etleva Joseph from Albania. I have a question.
Hey,
According
close.
according with your collaboration with chirurgs, when we have a large nodule with clinical expression, and it's surely for thyroidectomy, is helpful to have fine needle aspiration before, if we have an indication because of the mass of the thyroid gland?
You are talking about, excuse me, you are talking about multinodular goiter with pressure symptoms?
Or maybe just a nodule, increasing nodule with clinical expression that we decide to have operation.
Yes.
Will be fine needle aspiration
Yes,
helpful?
yes, I will.
For this?
Yes, I will.
Okay.
For us, the cytology is one of the. It's the same whether you see the patient, he looks like he's euthyroid, and you send him to the surgeon without doing TSH. For me, it's the same thing.
Okay.
I do TSH. I want to know. I have to be sure that he is euthyroid, and then I perform fine needle aspiration. Also, if the nodule looks like very good, because also. If he has a single nodule, big one nodule on one side, and the other lobe is okay, what you do?
No,
You do
Because
what do you advise to the
meantime, they
surgeon?
haven't
To make
frozen.
total thyroidectomy, lobectomy, you should advise lobectomy if you have fine needle aspiration which is benign. If it's malignant, you perform total thyroidectomy. If it's 4 centimeter and you have a T3 possibility of having a T3 cancer.
Sometimes, meantime, they do frozen biopsy, and this is a question. Is fine needle aspiration more specific that frozen biopsy, meantime?
Yes, in our experience, but also in the experience of most centers, cytology is more indicative than frozen section exam.
Okay, thank you very much.